So with this, I will call Dr. Swathi Kaliki to talk on retinoblastoma intravenous versus targeted chemotherapy.
Thanks, Anuswa. Very good morning to one and all present here. So I think so we have heard about different topics in this session, starting from the eyelid tumors to the intraocular tumors, the surface and the orbit tumors. So now we move on to one of the common intraocular tumors that we see, that's retinoblastoma. And I think the field of retinoblastoma is changing in such rapid pace that every 5 years we are having a new mode of delivery of chemotherapy. So when there are so many options that are available, it's very, very important to understand when to choose which option so that the patient has the maximum benefit from the treatment that you're offering to the patient. So in this context, let's understand what are the various forms of chemotherapy that are available for retinoblastoma and when to choose that particular form of chemotherapy. So now the retinoblastoma management is not very simple that you just have an algorithm and you just follow an algorithm. It certainly is not. Though we follow protocols for management of retinoblastoma, but still there are many factors that we have to take into account before we choose the form of treatment for a patient. Now, the various factors that we include when we have to treat a case of retinoblastoma, they include whether the tumor is unilateral or bilateral, because your form of chemotherapy or the form of treatment also depends on that. What is the size of the tumor? Is it that we are dealing with a very small tumor or whether we are dealing with a very large diffuse tumor? Whether the macula is involved or whether it is not involving the macula, whether it is associated with vitreous or subretinal seeding, whether there are presence, whether that eye is likely to harbor high-risk features, what is the age of the patient, whether it's a very young patient, say you're seeing a patient who is just few days old versus a patient who is few years old. Your choice of treatment again depends on that. What is the general health status of the patient? If you get a very emaciated child, so obviously you have to again think of what form of chemotherapy you're going to give for that particular child. And if there is any significant family history, that is if one of the parent has already had retinoblastoma, if there is risk of that child having a tendency to develop other tumors, so again your form of chemotherapy that you choose depends upon that. And of course, last but not the least, probably the most important, what is the expectation of the family from you when they get their child to you? Because there would be certain parents who would be like, okay, we will do anything, but we do not want the child to have side effects during treatment. Or there are parents who will be like, okay, we want the child to be saved with both the eyes, but we cannot afford very expensive treatment. Do whatever you can. So I think we also have to take into consideration the expectations, the desires of the patient and the family as well. So with this, let's come to what are the various forms of chemotherapy that are available. So the most common form, which is the intravenous chemotherapy, which has been around now for almost 4 decades. And it's a great form of treatment for retinoblastoma. And now the recently evolving form of chemotherapy that we have is a much more targeted chemotherapy. And I think we are in a very fortunate era where chemotherapy is being given into every possible cavity of the eye. It's not limited to only the intraarterial. Of course, it started with the intraarterial and the subtenons, but now we have progressed that we are also giving chemotherapy into the vitreous cavity. We are giving chemotherapy into the anterior chamber. So essentially, we are giving targeted chemotherapy to every possible cavity of the eye. Now let's start with the most common form of chemotherapy, that is the intravenous chemotherapy. The standard protocol that is followed by most of the ocular oncologists across the world is the use of vincristine, etoposide, and carboplatin, where we give the drugs on 2 different days, where all 3 drugs are given on day 0 or day 1, whatever you count it as, and the next day we give only etoposide. And the general protocol, and here we are talking of only the intraocular retinoblastoma. We are not talking about the eyes with extraocular extension. So the standard protocol that we follow is we give 6 cycles of chemotherapy. And it can be in the form of standard dose or high dose. Generally, we give the standard dose. High dose we choose in very rare cases where it is advanced in both eyes. And this is the standard dose that is followed by the medical oncologists who help us with the dose. Now, here are few examples of the eyes with the intraocular retinoblastoma, where you can see that on to your left, you see a smaller tumor, or maybe to your right, and then there is a larger tumor that is present on the other side. Now, these patients, which form of chemotherapy would you give? Again, it would depend on whether it is a unilateral. If these both eyes are belonging to the same patient, and we are talking of bilateral retinoblastoma, of course, you have 2 choices. One is you can give the intravenous chemotherapy, or you can do a tandem intraarterial chemotherapy where you give intraarterial chemotherapy to both eyes. In the West, yes, there are groups where they do the tandem intraarterial chemotherapy, where they do bilateral intraarterial, but that's not a common practice. In Indian scenario, again, there are various factors that we have to take into account, whether the patient can afford intraarterial chemotherapy to both eyes, and whether your interventional neuroradiologist is experienced enough that will cause minimal side effects during this treatment, because intraarterial chemotherapy can be associated with very serious side effects like the ophthalmic artery occlusion and the child losing the vision completely. Now, this child has received intravenous chemotherapy, and you can see that the tumor has nicely regressed into a very, very small tumor and has had a beautiful response. Now, here is another example, and these are the typical cases that we would see in our scenario, where they come with very advanced or large tumors in both eyes. And the intravenous chemotherapy definitely works very well even for the eyes with large tumors, where you can see that the tumor as such has reduced beautifully. Of course, it has left behind a large scar, which is going to cause a compromise in the central vision of the child. But nevertheless, we are able to save the eyes. It has its own side effects, of course, the intravenous chemotherapy, which can be a different session by itself, where each of the drug can have its own side effects. The most common being the carboplatin causing the ototoxicity and the vincristine causing the peripheral neuropathy. These are the common side effects, and of course they do have the temporary side effects which are expected with any form of chemotherapy, like the nausea, vomiting, and loss of appetite, all that you expect with any form of chemotherapy. Now, next, understanding the targeted chemotherapy, that is the periocular chemotherapy, which almost I would say is obsolete now. Maybe only in countries where intravitreal chemotherapy is not yet in practice, they are still using it, but otherwise we hardly use this form of chemotherapy. It was used maybe about 10 years ago, but not anymore. So in this, the periocular chemotherapy, carboplatin is the drug which is injected into the subtenon space. And here is an example. This is a very old case where we had used the subtenon's carboplatin. But today, if I would be treating this case, I would rather give intravitreal chemotherapy than a periocular carboplatin. So this is the child before chemotherapy. Then after chemotherapy, you can see that before chemo, if you notice, there is an endophytic portion of the tumor that is there, and after chemotherapy, the vitreous seeds just got dispersed into the vitreous cavity. And so this patient, and we know that when we are giving intravenous chemotherapy, the minimal drug is delivered into the vitreous cavity, so it will not cause much effect on the vitreous seeds, though some amount of reduction is seen. So the child was combined with the subtenon's carboplatin, where you can see the child had very good response. And after 3 injections of subtenon's carboplatin, the child did very well along with the intravenous chemotherapy. But of course, the challenges with the subtenance carboplatin, those who have seen cases in the era where we used to do, is it causes fibrosis in the quadrant wherever you inject. So each time we used to change the quadrant. So if we have given in a, say, like inferotemporal quadrant, then the next visit we change it to another quadrant so that we are not increasing the fibrosis in that particular quadrant. The next, I think the most famous targeted chemotherapy is the intra-arterial chemotherapy. So in this, of course, it is done by an interventional neuroradiologist, where the drug, the chemotherapy drug, is injected from the femoral artery, and you go through the common carotid, go into the internal carotid artery, and specifically target the delivery of the drug through the ophthalmic artery to the eye. So here is like, where the interventional neuroradiologist reaches till the ophthalmic artery, which is the first branch that comes out from the internal carotid artery, and then inject the drug. We typically use 3 drugs. This again, it varies from practice to practice, where few people use only single drug like melphalan, few people use only 2 drugs like melphalan and topotecan. We use melphalan, topotecan and carboplatin combination. Now here is in fact the first case that we had treated with intra-arterial chemotherapy. This child had already received 14 cycles of intravenous chemotherapy and still had recurrence. So when a child has received so many cycles of chemotherapy, whether you would want to treat this eye again with intravenous chemotherapy, that it's like not, because the cumulative dose of chemotherapy is going to cause side effects for the patient. So this patient, we chose to give intra-arterial chemotherapy. And you can see that after just 1 cycle of intra-arterial chemotherapy, the child had very good response. So this goes to say that I think we have to have an interplay between different forms of chemotherapy and know when to choose which form of chemotherapy. The next, the intravitreal chemotherapy, I think this is a landmark paper that I always like to show when I talk about this form of chemotherapy, because whatever we are doing today, the whole credit needs to go to Francis Munier, who showed that it is safe to inject in an eye with retinoblastoma, because it was traditionally taught that never put a needle into an eye with retinoblastoma, which probably doesn't stand true anymore, because we are putting needles now not just into the vitreous cavity but into the anterior chamber as well. So it is okay to inject a drug into the cavities. So this paper, this was the first paper that was published from the group, where they had used melphalan, and they showed that they had very good success rate, and none of the eyes developed extraocular extension after treatment. This again is one of the first cases that we had treated, where this child developed these vitreous seeds after 6 cycles of intravenous chemotherapy. You can see that there are multiple vitreous seeds that are present, not just adjacent to the tumor, but in the entire vitreous cavity. Now this patient, because intravitreal chemotherapy was kind of like just we had started doing, we thought first let us start with the periocular carboplatin, and we had started and given periocular carboplatin for this patient. But as you can see, it didn't respond very well. Okay, let me move a little quickly. Yeah. So then we gave this child, so this was the starting point when the intravitreal chemotherapy was given to this patient, and the vitreous seeds completely regressed with 6 injections of intravitreal chemotherapy. At that point of time, we were using melphalan, but with time, we have realized that many of these patients who receive melphalan eventually develop side effects, and at this point of time, we prefer to use topotecan over melphalan for intravitreal chemotherapy. I can take another 2 minutes. Is that okay? Okay. So this is another example. The reason that I want to show you this case is sometimes we are so focused on globe salvage that we forget about our goal of also the vision salvage. So this is a case, this was again when we were using only melphalan, where you can see that there are large vitreous seeds that were present. And this was again after the child receiving 6 cycles of chemotherapy. We gave intravitreal chemotherapy to this patient, and just look at the color of 2 things that you have to look at: what is happening with the vitreous seeds and the color of the fundus as well. So if you see, definitely the vitreous seeds have disappeared, but along with the vitreous seeds, it has also caused a lot of toxicity. So the toxicity, where you can see that the vessels almost are sclerosed. The temporal vessels, as you can see, they appear like the ghost vessels. So the vessels are sclerosed, and if you see the sheen that is seen in the first picture of a very healthy RPE is not there anymore in the fourth picture. So I think this was the case that we decided that we have to shift to a different form of chemotherapy, different drug of chemotherapy. We stopped using melphalan and shifted to topotecan, and our experience has been that topotecan causes minimal retinal side effects and has the same beneficial effect on the vitreous seeds. So melphalan, when we use at a dose of 20 to 30 microgram. If we use topotecan, we use 30 microgram in 0.15 cc. And now we have also started, hopefully next year I'll be presenting more data. We have also started doing high dose intravitreal topotecan for selective cases. We have specific indications for that, and we are seeing good response with that as well. The most important thing, I think, when we give intravitreal chemotherapy is to understand that though it is safe to put a needle in an eye with retinoblastoma, yet we have to be very, very careful that you do not want to be going into the eye through the retinoblastoma. So you have to choose a quadrant where there is no tumor. And the most important step, and which differentiates from other routine intravitreal injections, is that you do cryotherapy at the site of injection. So this is the triple freeze thaw cryotherapy being. So even before you withdraw the needle, you put the freeze, and through the freeze you're taking out the needle, just so that if there is any escape of the vitreous seeds, it is taken care of by cryotherapy. And we complete the triple freeze thaw cryotherapy cycle by completing 2 more cycles of cryotherapy at the injection site. Okay, I think I'll skip this. Yeah, going to the last bit, that's intracameral chemotherapy. Now, intracameral chemotherapy is the newest form of targeted chemotherapy that is currently available. And it is a very tricky form of chemotherapy. Not every case is suitable for intracameral chemotherapy, but yes, there are cases which will benefit from this form of chemotherapy as well. Our experience has been that we have done in 5 cases where we have given intracameral chemotherapy. 2 cases ultimately ended up with enucleation, but there are 3 eyes which could be saved with this form of chemotherapy. And again, the due credit goes to Francis Munier here again, where he was the first one to describe the bicameral technique of intracameral chemotherapy for aqueous seeding in retinoblastoma. So intravitreal chemotherapy we use when there are vitreous seeds. Intracameral chemotherapy we use when there are aqueous seeds. Now, what are aqueous seeds? Aqueous seeds are, you can see that there are tumor deposits that are present in the aqueous. They can be dust, spears, or cloud, or it can be a combination, which is the most common form. I will skip through these slides in the interest of time and just go to the technique. Okay, so the way that we do intracameral chemotherapy, intracameral chemotherapy is we go into the anterior chamber, aspirate the aqueous, then go into the posterior chamber, aspirate the aqueous from there, then we inject the chemotherapy in the posterior chamber and the anterior chamber, and then we do triple freeze thaw cryotherapy before we bring out the needle. So this definitely, it requires a lot of expertise. It cannot just be done in every case by anyone. So we have to be very careful when we are doing this particular technique. And here is an example. So this is the same case so this is the case where there were aqueous seeds to begin with, and there were seeds that were present in the posterior chamber as well, which can be seen on ultrasound biomicroscopy. And you can see after 1 injection of intracameral chemotherapy, the child did very well, where the aqueous seeds completely disappeared. We had given a combination of intracameral and intravitreal chemotherapy in this case. So I'll end with the last slide. So this is the case. So this is a one-eyed patient who has come to the clinic. He has already lost one eye because it was very advanced tumor. So enucleation has been done, and this is the advanced tumor in the only eye of the child. And because the enucleated eye also showed high-risk features, anyways, this child had to receive intravenous chemotherapy. Now, this is after intravenous chemotherapy. As you can see that the tumor is nicely reduced in size. There are few seeds that are still active, which we were doing focal treatment, but after few days, he comes back with this. By then, he had already received 12 cycles of intravenous chemotherapy, but now has these multiple vitreous seeds and tumor recurrence. So what would you do? So you definitely have to combine with targeted chemotherapy. So here we've used two forms of targeted chemotherapy, that is intra-arterial chemotherapy in combination with the intravitreal chemotherapy as well. And now this child has completed almost 6 to 7 years of follow-up and is still keeping the eye. So I think whenever we talk about chemotherapy, we have to choose wisely. There are cases which require the targeted chemotherapy, and there are cases which require intravenous chemotherapy. So all forms of chemotherapy work, but not in all cases, all forms of chemotherapy are required. So with this, I end my talk. Thank you.